Welcome to the North Country Initiative Dsrip 101. Dsrip, with a Delivery System Reform Incentive Payment Program, is a New York State initiative in partnership with the Centers for Medicare and Medicaid Services designed to reduce avoidable hospital and emergency department use by 25% over the next 5 years. The following video provides information to help you better understand Dsrip and how it will impact patients and healthcare providers across New York State and the Tug Hill Seaway region. It will also help you better understand how the North Country Initiative is responding locally to this federal and statewide program. Our current fragmented, competitive fee-for-service system is unsustainable. So providers are making a fundamental transition which involves collaboration, integration, and mutual accountability. This is a cultural shift away from a siloed fee-for-service approach where communication is fragmented to a value-based care where providers are paid based on the value of care they deliver instead of the number of services they provide. This future system encourages collaboration and mutual accountability among all partners. An increasing number of patients are using hospital emergency departments for non-emergency primary care. Reversing this unsustainable trend requires increased access to primary care services, eliminating wasted services, leveraging community-based resources, and shifting from a culture of treatment to one of prevention. This shift to clinically integrated care will help reduce costly admissions and move us closer to our Dsrip goal of reducing avoidable hospital use by 25%. Clinically integrated care is dependent upon 4 factors, or pillars, implemented to link clinical outcomes to cost management, with the aim of negotiating value-based payer contracts. This will also help assist our Dsrip efforts. Pillar 1 is establishing a collaborative leadership. A shared governance with strong physician leadership is essential. Pillar 2 involves aligning incentives. Clinically integrated networks must develop structures that align goals and incentives across the entire spectrum of providers. Pillar 3 relates to clinical programs. The heart of clinical integration is care coordination. Greater coordinations between providers will improve patient outcomes and decrease costs. And Pillar 4 is a technology infrastructure. System integration, point-of-care tools, and data analytics will help foster hospital-physician collaboration and patient engagement. In 2014, New York State secured an agreement with CMS that would allow the state to reinvest $8 billion of the $17.1 billion in federal savings generated by the Medicaid redesign efforts. This reinvestment will facilitate our transformation to a sustainable system and increase access to efficient, high-quality health care. In addition to reducing avoidable hospital use, providers will focus on areas of system transformation, clinical management, and improvement in population health. This initiative is helping to transform the state Medicaid program through the development of a network of providers, including hospitals, physicians, community-based organizations, behavioral health clinics, nursing homes, emergency medical services, and other types of healthcare entities. This network is called a Performing Provider System, or PPS. The objective of the PPS is to provide high-quality, effective care across the continuum, thus supporting Dsrip's primary goal. The North Country Initiative is the designated PPS, serving the Tug Hill Seaway region. The Dsrip program allows PPSs to request regulatory waivers from the state to facilitate collaboration and the integration of services such as primary care and behavioral health. Dsrip is a 5-year program. The NCI is one of 25 PPSs in New York State. Year 0 began April 2014. PPSs were required to submit a planning design grant containing an organizational application and a project plan. They were also required to submit between 5 and 11 projects outlining project-specific requirements and strategies. Project selections were based on the Community Needs Assessment. The North Country Initiative chose 11 projects. A PPS can receive payments in numerous ways. Each project has required milestones and tasks. All milestones and tasks must be completed within a designated time frame in order to receive payment. Each process measure and milestone will be evaluated and given an achievement value, indicating the level of achievement. Also related to payment in each project is the speed and scale of patient engagement along with provider engagement. Each PPS will be responsible for improving the clinical quality of care for the Medicaid beneficiaries that are attributed to their PPS. The chart illustrates yearly Dsrip project funding based on the performance and reporting. Dsrip payments are based on the performance of the PPS and not the individual providers. Entities that may have been competitors in the past will find it necessary to work together to achieve the best patient outcomes. The Tug Hill Seaway region is home for the North Country Initiative. This rural tri-county region is spread over 5,224 square miles, with a population of over 262,000 residents. The population density is approximately 50 persons per square mile compared to the statewide estimate of 411 per square mile. While we are one of the smallest PPSs across the state, we cover one of the largest geographic regions. The Tug Hill Seaway region is also home to the Fort Drum 10th Mountain Division. While they are not Medicaid beneficiaries, the presence of the Fort Drum Army installation makes the delivery system in the North Country unique because our community healthcare system supports the soldiers and their families. Each PPS was required to conduct a regional community needs assessment to determine the region's health status, components of the healthcare system, and available community resources. This assessment ensured that the selected Dsrip projects are addressing the greatest needs of the community. This slide depicts some of the key findings of the assessment. The North Country Initiative was formed to facilitate shared governance and healthcare service restructuring to reduce the cost of care and improve the quality and experience of care for the residents of the Tug Hill Seaway region. The NCI is a physician-led, hospital-capitalized, multi-stakeholder collaborative. The NCI PPS includes over 500 physician and community providers in independent practices, hospital-owned clinics, behavioral health organizations, schools, public health agencies, federally qualified health centers, home care agencies, long-term care facilities, and the following 6 hospitals: Carthage Area Hospital, Claxton Hepburn Medical Center, Clifton Fine Hospital, Messina Memorial Hospital, River Hospital, and Samaritan Medical Center as the safety net lead applicant. Each PPS is required to have a governance structure whose purpose is to make decisions about funds flow, establish clinical metrics that will be reported and monitored, enhance provider participation and accountability, and execute Dsrip-specific projects. The governance structure must include financial, clinical, information technology, and data components. The governance structure is critical to the success of the PPS. NCI PPS partners make up the membership of these committees. The blue boxes represent pre-existing Fort Drum Regional Health Planning Organization committees, and the green boxes represent NCI committees. The next few slides walk you through the 11 projects selected by the NCI. The 11 projects selected were chosen from 3 of 4 domains: organizational, system transformation, clinical improvement, and population health. In order to reduce avoidable hospital use by 25% over 5 years, each PPS must work on projects specified in its application. Here are the projects selected. Project 2AI focuses on creating an integrated, collaborative, and accountable service delivery system that incorporates the full continuum of care. This project aims to eliminate service fragmentation while increasing opportunities to align provider incentives. This project will facilitate the incorporation of medical, behavioral health, post-acute, long-term care, social service organizations, and payers to transform the current delivery system from one that is institutionally based to one that centers around community-based care. By leveraging connections to the Health Information Exchange or by using direct messaging and other population health management strategies, the NCI Integrated Delivery System will be prepared for active engagement in New York State's reform efforts. Project 2A2 aims to transform all safety net providers and primary care practices into NCQA 2014 Level 3 patient-centered medical homes. The PCMH model is transformative with strong focus on evidence-based practice, population management, coordination of care, HIT integration, and practice efficiency. Such practices will be imperative as the healthcare system transforms to a focus on community-based services. This project will address those providers who are not otherwise eligible for support in this practice advancement, as well as those programs with multiple sites that wish to undergo a rapid transformation. Project 2A4 is aimed at reducing excess bed capacity and repurposing the unneeded inpatient hospital infrastructure into medical villages or integrated outpatient service centers, providing emergency or urgent care as well as access to the range of outpatient medicine needed within that community. As more services are delivered in outpatient settings, the state envisions Dsrip as a way to allow hospitals to reduce their inpatient bed capacity while expanding other services in the continuum of care that meets the needs of the community they serve. Project 2B4 is focused on providing a 30-day supported transition period after a hospitalization to ensure discharge directions are understood and implemented by the patients at high risk of readmission, particularly those with cardiac, renal, diabetes, respiratory, or behavioral health diagnoses. The PPS will develop and implement standardized and systematic care transition protocols from the hospital to various care settings, including primary care, nursing home, behavioral health organizations, and community-based services. The NCI will also explore a standard protocol to identify and refer health home eligible patients. Project 2DI is focused on patient engagement. It involves the establishment of training teams, training providers on patient activation techniques, promoting preventative care, developing community navigators, and educating community navigators about insurance options and healthcare resources. These resources will help the uninsured, non-utilizing, and low-utilizing populations gain access to the benefits associated with Dsrip projects. Project 3AI is focused on the integration of behavioral health and primary care, so that care for all conditions is delivered under one roof by known healthcare providers. This type of integration serves to identify behavioral health diagnoses early, allowing for rapid treatment. It also serves to ensure treatments for medical and behavioral health conditions are compatible and do not cause adverse effects. Finally, integrating behavioral health and primary care services helps to destigmatize treatment for behavioral health diagnoses. Project 3BI supports the implementation of evidence-based practices for disease management for adults with cardiovascular conditions. The PPS will adopt nationally recognized clinical guidelines. We will incorporate the use of the 5 A's for tobacco cessation, and we will ensure staff are involved in measuring and recording blood pressure using correct measurement techniques. Interdisciplinary care teams will be integral in the adoption of activities that will increase patient self-efficacy and confidence in chronic disease self-management and lifestyle changes. The goal of 3CI is to ensure clinical practices in the community and ambulatory care setting use evidence-based strategies to improve management of diabetes. To increase patient self-efficacy and confidence in self-management, the NCI will develop care coordination teams within primary care practices. We will also leverage, implement, and cover the cost of systematic referrals to the local, nationally recognized diabetes prevention program. Project 3C2 aims to develop community resources and foster collaboration with community practitioners. The PPS has identified hotspots within the Tug Hill Seaway region. We are conducting community forums in these hotspots to better understand the needs of the beneficiaries. We will also train and deploy community health workers to assist patients with preventative strategies for reducing their diabetes and other chronic disease risk factors. Participatory hotspotting will help us to facilitate the coordination of scarce resources and apply them to disparate areas. It will allow us to leverage the grassroots intelligence of partners in churches and underserved neighborhoods, and it will help us develop interventions that directly address the social determinants driving disparities. Project 4A3 is a population-wide project. This project supports collaboration among leaders, professionals, and community members working in mental, emotional, and behavioral health. This is a relatively new field, requiring a paradigm shift in approach and perspective. The NCI will focus their efforts on binge drinking and preventing suicide, as the community needs assessment indicated that our rates are nearly double the statewide average. Project 4B2 is also a population-wide project. Chronic disease preventative care and management can help alleviate chronic disease-related complications. These services have been shown to be cost-effective, but many New Yorkers do not receive the recommended preventative care and management. By choosing this project, NCI is seeking to increase the number of residents in the Tug Hill Seaway region who receive evidence-based preventative care for chronic diseases. We will focus our efforts on COPD, tobacco, and colorectal cancer screenings, as these were areas of need demonstrated in our community needs assessment. Now, tracking and documenting your work and the work of the entire PPS is critically important to ensure we get credit and payment for the work being done. This slide depicts 3 ways in which the NCI will be tracking, monitoring, and evaluating the progress of our commitments. We and the State Department of Health will be utilizing these 3 mechanisms to run reports and monitor performance versus metrics, with the overall goal of improving the quality and experience of patient care and reducing costs. The NCI will be securing agreements and contracts with regional partners. We will then meet with each partner to review their entity-specific commitments. Organizational and project activities are underway and will continue through March 2020. Throughout this process, the NCI will be submitting quarterly reports to the New York State Department of Health. As seen earlier, we will initially receive payments for reporting, but as Dsrip continues, these payments will shift to pay for performance or value-based payments. The PPS's Project Management Office is here to support the work of our partners and leverage the resources and partnerships that currently exist. As you may have noticed, many of the tasks associated with our 11 projects are cross-functional. For example, the strategies being implemented through the integration of behavioral health and primary care will be accomplished through PCMH. It's not necessary to reinvent the wheel. The key to success is leveraging cross-functional goals, sharing best practices, and documenting deliverables electronically. The PPS wants to ensure our partners stay informed and engaged. Communication, transparency, and trust are critical to the success of this initiative. Here are some Dsrip key points. Thank you for watching Dsrip 101. Here is our contact information in case you have any questions.